Right. Hi. So I've been asked to talk today about symptoms that men with adrenal neuropathy can suffer and how we can currently try and relieve them a bit. And I'm going to talk about three different aspects of the disease. We're going to talk about symptoms due to spinal cord disease, which are those that affect your legs and your bladder. And erectile dysfunction. We're going to talk about symptoms related to disease in the peripheral nerves, which is really numbness of the feet. And we'll talk briefly at the end a little bit about adrenal failure and how you manage that. So let's start off with spinal cord disease. So in adrenal neuropathy, you get a problem with the communication through the spinal cord. And that means that the neurons up here in the brain can no longer communicate with the neurons down here in the spinal cord. And so if we think about the neurons in the spinal cord that are controlling the muscles in the legs, if there's a block in the communication between neurons in the brain and those motor neurons in the spinal cord that are directly controlling the muscles in your legs, what happens isn't that these neurons stop working altogether and you get a paralysis. Actually, they start working more. They become uncontrolled and you get uncoordinated action, uncoordinated firing of these neurons that causes a contraction of the muscles. And that can lead to the brisk reflexes and the spasms you get in the legs. And it also leads to the general stiffness of the legs. Those muscles are contracting more than they normally would because they're getting more input from these neurons in the spinal cord. And that's what leads to what we call spasticity, stiffness of the muscles. And that actually affects different groups of muscles differentially. And in the legs, that's what leads to the characteristic spastic gait we see initially with the muscles that pull the foot down being tighter than the muscles that pull it up. So you get this foot drop, dragging of the toes of the gait, and we'll come back to that later on. And then eventually spreading up to involve the muscles in the thighs as well. So you get what's called this scissored gait, where the legs are pulled across each other as you walk, making it very difficult to walk. And when we try and treat that, there are basically two things we try and do. We try and relax the muscles a bit in order to, one, relieve pain, but two, improve function. So the idea is that perhaps by reducing some of that abnormal input into the muscles, you can get more normal function and improve walking. And there are a number of different ways to do this. It can be done using drugs, which can either be taken by mouth, or given by injection, either directly into the muscle or indeed into the spinal cord. So let's start with the oral drugs we use, the oral antispasticity drugs. And these are things like baclofen and tizanidine. Normally we'd probably start off with baclofen. Baclofen is very effective at reducing the tone, reducing the stiffness in the muscles, and that can help reduce the pain and reduce the spasms as well. But one of the problems it has is that when you reduce the stiffness in the muscle, you can also unmask the fact that the muscle is weaker, not as strong as it used to be. And so if you're relying on stiffness of that muscle to keep you up, to keep you walking, then baclofen can actually have an adverse effect on your mobility, because actually it means that you're not able to maintain your weight on your legs anymore. It's also got some systemic side effects, particularly drowsiness. A lot of people feel a bit sleepy and out of it with baclofen. That can often wear off after the first couple of weeks and gets better at that point. And it's one reason why people prefer taking it at night, perhaps to deal with spasms in the legs at night, rather than taking it regularly through the day to deal with the spasticity. Tizanidine works by a different mechanism, so it doesn't have the same side effects, but it has side effects of its own. It can cause some dry mouth, it can cause some tummy problems. There's a risk of hepatitis, so people tend to measure your liver function when you're on it. And then these other agents, dantrolene can occasionally be used, though again has some side effects. And gabapentin we tend to use more often for pain, and we'll come back to it when we're talking about treating peripheral neuropathy. But it does also have an effect on spasticity as well. Sorry. Okay, So those are orally active drugs that can help reduce spasticity because, like all systemically given drugs, tend to have side effects. What about more direct treatments? Well, we've said that when you have a block in the transmission of energy information down the spinal cord from the neurons in the brain to the motor neurons in the spinal cord, that leads to these motor neurons becoming overactive and giving too much input to the muscles. So another way of trying to address that might be to block that input to the muscles in order to try and treat the condition. And that's what we do with botulinum toxin. So botulinum toxin is a toxin that actually stops the neurotransmitter that's released here by these neurons onto the muscle that makes them contract. It basically stops that from working. And it can be given very accurately by injection into single muscles, into parts of single muscles. And so instead of having a systemic effect, like when you give baclofen by mouth, you can actually have a very local effect to effectively paralyze muscles that are too active in spasticity. And in spasticity, the way that tends to get used is very specifically to try and improve the gait. And so we've said that one of the early problems is that this muscle at the back of the calf tends to be too tight, too stiff, and that's what pulls the heel up and the foot down. And that's what leads to problems with dragging your toes and tripping. And so by using baclofen specifically into this muscle, we can actually partially paralyze that muscle so that it becomes less stiff, so that the foot becomes flat again, and you're able to walk more normally. This toxin works for several months, but it does eventually wear off. And after 6 to 12 months, you'll note the tone will come back again, the problems will recur, but you can then repeat the treatment again, although over time, the muscle will atrophy. That means waste away. So this can be very useful in treating localized spasm, localized spasticity, and certainly can help improve gait and sometimes deal with pain in muscles that are very painful because they're contracted. And the final drug treatment is using baclofen again, but instead of giving it orally when there's the risk of all those side effects, drowsiness in particular, I'm giving it specifically, this time not to the muscle, but to the spinal cord. So by putting a little pump in and infusing baclofen through a catheter into the lower spinal cord, the idea is that it can have its effects on those neurons without affecting the rest of the body as well. And this can be very effective and is used widely in some places for treating the spasticity in multiple sclerosis. I'd have to say that certainly in our own practice, we haven't seen it used very much, but it may be an option you come across. Okay, what about non-drug interventions? And these are actually very useful as well and very important, and a lot of them come under what we consider to be physiotherapy interventions. Splinting can be very useful. So we talked about stopping the foot from dragging by using botulinum toxin to the back of the calf, but you can also do that by using splints that just pull the foot back up again, and lots of people have had experience of those. Stretching is very important. We think it's very important to keep the muscles as loose as you can, to maintain flexibility over time, and exercise is very important. And a lot of this physiotherapists can help out with as well. The last one of these, functional electrical stimulation, is actually a medical device, again, that's designed to improve walking in people with spasticity. This is using a electrical stimulator and wires, this time to stimulate the muscle at the front of the calf, at the front of the leg, that's responsible for lifting up the toes. So with botulinum toxin, we were trying to paralyze the muscle at the back of the leg that was pulling the toes down. Now we're trying to give much better, stronger and more coordinated contraction to the muscle at the front of the leg that pulls the toes up. And the idea is that you have a sensor up here that detects at what point during your stride you are, where the leg is. And when the leg is coming forward here, and normally the toe stays down and catches on the ground, this then sends a signal to the nerves that supply this muscle, telling it to contract, and hopefully pulls the toe up so that your walking is coordinated again. You're not getting that dragging of the foot, and it can certainly markedly improve the gait in people who respond to it. Unfortunately, not everybody responds to it. The peripheral nerves need to work as well, and if you have neuropathy, that sometimes isn't the case. But it's often worth a try. Lots of spasticity clinics will have this technology available, and be able to see whether it works for you or not. And the last thing is mobility aids. So these are very important as well. Anything from a stick or a crutch through to a frame, a wheelchair, and an electric buggy that allows people to get around. And these, often in a progressive disease, you will end up needing these at some stage. They're very important in, one, preventing falls, making sure you're more stable, preventing all the fractures and things that can go with those falls, but also in maintaining independence. So it's very important that you can get around and maintain independence. Often people regard these as having a stigma attached with them, walking with a stick, particularly using something like a buggy. But in fact, once you accept that and go on to use the relevant things, normally they make your life much easier. So we tend to find that people are much too slow in moving from a stick to a crutch to a buggy. And actually, if you accept the fact that you need some help getting about long distances around town and are willing to have a buggy, and that improves your independence, it makes it much easier and quicker to get from A to B, so that when you get to where you're going and perhaps revert to just using a stick or a crutch, you've got much more energy, you've got much more time to get around and do what you need to do. Okay, so that's dealing with the muscles and the spasticity we see in adrenal neuropathy. What about dealing with the bladder? So bladder disease is also due to a block in the spinal cord, so that the neurons in the brain can no longer control the neurons that are controlling bladder function. And the bladder is in fact a bag of muscle. It's a balloon with a muscular coat that holds the urine until the time then you want to get rid of it and have a pee, and then that muscle contracts and squeezes the urine out down the urethra and out of the penis. And normally that's very well coordinated. The muscle relaxes until the time when the bladder is full and you want to contract it, in which case when you open up the urethral sphincter down here and contract the bladder muscle, and that's when you urinate. So a normal bladder, the muscle, the detrusor muscle, that's what we call the muscle of the bladder, is normally relaxed until the bladder is full of urine, and then it starts to contract, but it doesn't contract properly until you're ready for it to do so. Whereas in disease of the spinal cord with spasticity, as well as overactive muscles in the legs, you get an overactive bladder muscle. And again, this then becomes a very unstable bladder. It can contract even when there's only a small amount of urine in the bladder. And perhaps just as importantly, when it does contract, it no longer contracts in a coordinated manner, and it normally doesn't get rid of all the urine from the bladder. So after you've finished urinating, although you may not have passed very much urine because the bladder wasn't very full, it also won't be fully empty at the end. And that's a problem, because when you have urine that doesn't get out of the bladder and sits around, that can get infected. And that's why urinary tract infections are much more common in people with these sort of problems with spinal cord related problems with the bladder. So you have to go to you feel the urge to go to the loo when the bladder isn't entirely full. So that's where what we call the urinary urgency comes from, having to go to the loo much more commonly than others. This bladder muscle is very unstable and can start contracting when you don't want it to, and that's what gives you the urinary urgency, having to go off suddenly. And occasionally it will contract even when you're not ready and will force urine past the urethral stricture, and so you'll get urinary incontinence as well. And because it doesn't empty completely, because there's stagnant urine left in the bladder for long periods of time, that can get infected. So how do we treat that? Well, basically, this is a flowchart, but basically there are two ways of treating it. You can either use drugs or you can use catheters. The drugs we use tend to start off with a class of drugs called Antimuscarinics that basically, again, try and block that transmission of nerve impulses between the overactive nerve cells and the bladder muscle itself. The antimuscarinics are things like solifenacin, tolterodone, trospium, Vicicare. These are also, like the drugs like baclofen, because you give them systemically, have side effects, and they can certainly lead to dry mouth. They can lead to various other problems as well, and aren't necessarily very well tolerated by everybody. increasingly now, where we used to use the new drug mirabegron only after you tried these, but actually increasingly they're thinking about using mirabegron before you try these other drugs, because it has fewer side effects, although it does side effects of its own. And all of these are basically aimed at stabilizing the bladder, at reducing those uncontrolled contractions, and hopefully allowing the bladder to fill more before you need to go to the loo, and to give a more coordinated contraction. They will work up to a point, but there will come a point when they are no longer effective either in stopping the bladder from contracting, or there will come a point where actually you have so much residual urine left in the bladder, when the bladder contracts, it doesn't contract efficiently, and the urine left is becoming a constant source of infection. And that's when they start thinking about going to urinary catheterization. And there are basically two forms of catheterization. You can either do it yourself from time to time, so intermittent self-catheterization, where you pass a catheter yourself up the penis into the bladder, allow the bladder to empty completely, and the advantage of this is it will empty the bladder completely. If you do that before you're about to go somewhere, first thing in the morning, last thing at night, then you've emptied the bladder, and you can be much more confident that you're going to be able to go for the next few hours without any accidents. This isn't always possible, or it may become impractical over time. You may have to do it too often, and then you can go for some form of permanent catheter. And rather than putting a permanent catheter up the urethra from the penis, the easiest way to do this in the long term is actually to put it through the abdominal wall into the bladder. So there's a tube going in through your tummy wall into the bladder. This is connected up to a bag that can be attached to your leg. It's constantly draining the bladder, so and the urine comes out down the catheter rather than going out down the urethra. So there's no problem with incontinence. There's no problem with having to go to the loo, and it can give you a lot more independence to go about your daily business. All catheters have potential problems with them. Obviously, with intermittent self-catheterization, you've got to be able to do it. And you're also introducing a foreign body into the bladder every time. So you have to be very careful to make sure it's clean and you're not introducing bacteria and causing infection. And the bacteria can also be a problem with a suprapubic catheter. So they need to be carefully looked after. The other related issue to the nerves in the pelvis that supply the bladder is that they also supply the erectile machinery in the penis, and erectile dysfunction can certainly be a major problem for patients with adrenal neuropathy. It's treated in a very similar way to the way it's treated for anybody else, so using drugs like Viagra and the newer versions of Viagra, injections that you can give in order to get blood into the penis and sustain an erection, and other devices and implants as well as required. It's certainly very treatable, and again, referral to your urology clinic will give you access to those treatments. So thirdly, we were going to talk about disease in the peripheral nervous system. So we've talked about disease in the spinal cord that takes information from neurons in the brain to neurons in the spinal cord or by the spinal cord. That's what we call the central nervous system, the brain and the spinal cord. The peripheral nervous system, the nerves, take information from neurons in the spinal cord or in the brain or close to the spinal cord to the periphery, to muscles and to the skin. And so we have both nerves that are taking information away from the brain and spinal cord to the muscles. So here we've got a neuron in the spinal cord that's controlling the muscles, and the information is flowing outwards. But there are also lots of nerves that are bringing information into the spinal cord and the brain. So here we've got receptors in the skin that may be pain receptors, receptors for temperature, receptors that actually tell you where a joint is or where your foot is in relation to the rest of your body, for instance. And they're actually taking information from those receptors into the spinal cord and then up to the brain, so that the brain can process that information and knows when you're hot, when you're cold, but also when you're upright or lying down. And these are very important in adrenal neuropathy, and actually probably it's disease in these afferent nerves, the nerves that bring information into the brain, that causes more symptoms than disease in these efferent nerves, where actually it's disease in the spinal cord that's causing the problems we see. And that's what we call peripheral neuropathy, so disease in the nerves that provide sensation, in this case, to the foot, and that leads to a number of problems. So if you can't feel anything, you get numbness and tingling. You can also get pain, if the nerves aren't working properly, you can end up interpreting stimuli as painful, which wouldn't normally be painful to other people, sensitivity to touch and shooting and burning pain. Conversely, although the feet may feel painful when they're not supposed to, when they're supposed to feel painful, you don't get that information. So if you're treading on something hot, for instance, or if you cut yourself, you may not be aware of that. And that can lead to real problems, because if you're not aware that you're burning yourself or that there's a cut on the foot that needs protecting, you don't do that, and you can end up with ulcers and nasty wounds that can take a long time to heal. And then increased falls. This is because, as we said before, there are receptors here that don't just tell you about pain, they tell you about joint position sense, about whether this ankle is bent or straight, about whether these toes are pointing up and pointing down. And if those aren't working properly, you don't actually know where your feet are when you're walking. So as well as a problem with controlling your feet, you also don't know where they are, and that contributes to increased falls, something we call sensory ataxia. And that's why you may have had this done when you have a neurological examination. We'll get you to stand with your feet close together, looking straight ahead, and you're fine and stable when your eyes are open. But as soon as you close your eyes and you lose that information from the visual cortex, you're no longer getting the information from your ankles and feet that tells you whether you're upright or not, and you begin to sway about like anything. And that's due to a problem with the peripheral nerves. How do we manage that? Well, firstly, you have to be very careful with your feet. So instead of cutting your own toenails, we recommend chiropody, people to do that professionally and make sure that they're not introducing small nicks and cuts. If there's neuropathic pain, we can try and treat that with drugs that basically interrupt with the flow of information up those nerves. So amitriptyline at night, pregabalin we talked about earlier. And again, unfortunately, because all of these are tablets, they can have side effects. Pregabalin in particular can make people feel quite drowsy to start off with, although again, you get used to it over time. And eventually we probably refer to a pain clinic if it needed more than that. And there are lots of different things they can try, including things like TENS, spinal cord injections that can sometimes help with pain. And then the other issue is, as I've said, that the peripheral neuropathy can also contribute to falls. So it's falls prevention, making sure you're using sticks and walking aids that make you as stable as possible. And lastly, I was going to briefly mention adrenal failure. So adrenal failure is part of adrenal myeloneuropathy in a proportion of patients. Actually, the problem with adrenal failure is that you don't always get symptoms. And therefore, you can think you're absolutely fine until you get an infection and your adrenal glands are not able to release the steroids to fight that infection. People can end up being very unwell in what we call adrenal crisis. But other people can get more long-lasting symptoms. You can feel generally fatigued. You can get changes in the way the kidney handles salt, and people can get short of sodium, which can lead to problems with the cardiovascular system. And you can also get an abnormal pigmentation of the skin. So people can develop what looks like a suntan in the middle of the winter and things, and that's because there isn't enough activity in the adrenal glands. However, it's detected. The way it's treated is by replacing the steroids that the adrenal glands are supposed to produce. And so we use hydrocortisone, which is sort of the anti-inflammatory steroid, if you like, and fludrocortisone, which is the steroid that works on the kidney to maintain salt balance. And we let endocrinologists do that on the whole. I certainly wouldn't be an expert in that. But basically, you end up with a certain baseline steroid replacement to give you your day-to-day requirements. But then if you become unwell for any reason, the doses have to be increased to make sure you're getting all the steroid you need at that time. Okay, so I've probably gone over that rather quickly, and hopefully there'll be some time for some questions along the way. But I think the take-home messages are that really what we're trying to do, the major issue here is the spastic paraparesis, the peripheral neuropathy to the feet and the lower limbs, and we're trying to keep you mobile as long as we possibly can and to keep you independently mobile as well as we can. And I think the key there actually isn't so much the drugs. They can be very useful in controlling symptoms at night, such as spasms and stiffness, but it's much more the aids and making sure you have the aids you need and using them early enough in the course of the disease so that they actually give you some benefit. So it's important in all these things that if you have symptoms, you talk about them and you get referred to the right doctors, because we should be treating those symptoms before they become a major problem for you. Okay, and I'm going to stop there, I think.